Ani, Miigwech, Elder Amelia, and thank you for that welcome, traditional welcome to start us off in a good way. And I also acknowledge our pleasure to be here on Kahnawake Mohawk territory. Thank you, the Canadian Academy of Health Sciences and Carol Herbert, for the honor of not only being able to give this lecture, but to become a fellow this evening. I'm looking forward to it. Thank you, Alain. It's actually a real pleasure. I have both of my bosses here, my CIHR boss and my Simon Fraser boss. So thank you, Alain. Thank you, John. It's been a great pleasure to be involved with CIHR over all these years. I've been almost 8 years as scientific director. I'm looking forward to new challenges next year when I can get back to more research and teaching and continue to be interested in CIHR. So I'm here today. First of all, and we do start off in a good way, and even I have to say it's great to see our Prime Minister acknowledge territory whenever he goes anywhere, and I think it's an important thing to recognize the people who were here and who continue to be here. And it's also important, this is a little bit of a teaching session. I've become a teacher of indigenous health these last 3 or 4 years at Simon Fraser, so I hope you'll forgive me. Part of what I'm going to give today is the same material I give to my students at Simon Fraser, so don't take it badly. We teach our students, and by the way, I acknowledge my wife Alexandra, who's sitting there, because we co-teach courses at Simon Fraser in Indigenous Health, and John has given us that opportunity. We start off by situating ourselves because it's important to have your own lens, and everyone has a unique and different lens. So, oh dear. This is some of my lens. In the middle is a picture of my late parents, Lloyd and Margaret. Lloyd King was a member of the Mississaugas of New Credit, as I am, and he lived on our reserve all his life. My mother, Margaret, came from Switzerland at the end of the war and lived out her life on that reserve. I was born on the reserve and grew up there, but then went away to university. But I maintained my connections, and over on the right you can see a picture of me with my father and my brother, and then there's a bunch of other pictures, relatives, and these are all very important because it helps to situate yourself, your lens is important to how you see the world. Now, I'm honored to have been offered the chance to give this lecture, and this is what's in your program, the stated goal. I don't, as Dr. Herbert said, I don't want to dwell on the past, but I think it's important for us to understand how we got here in order to be able to understand how to move on. So in the second paragraph, I note that fellows will walk away from this event with an increased awareness of the promising practices that are making a difference in these communities. This is a tall order, but it's what we need to do. It's not sufficient just to understand the past, to understand all of the morbidities and difficulties, but to learn from them, to learn how they got there, and to learn the practices that need to help us overcome, and most important, to work with our communities. I will spend the next half hour or so elaborating on that, but if that's the one message you can take away, it's working, as Dr. Baudet has said, working by and with our indigenous communities and leadership. I think this will be familiar for many of you, but again, not all Canadians appreciate these facts. We're a fairly small group, a percentage of the Canadian population, 4.3% overall in the 2011 census. It might be closer to 5% by now because it's growing. And in provinces like province of Quebec, it's barely 2% of the population who are indigenous, First Nations, Inuit, and Métis. But when we get to the prairie provinces, Manitoba and Saskatchewan in particular, the percentage of indigenous people is up in the 16% range. Thank you, John. And when we get to our northern territories, you see those percentages go up even higher. And of course, Nunavut has a great majority population who are indigenous, primarily Inuit. And Inuktitut is spoken by the majority of people up there. The other slide I've got is the demographics, and one can see that we're divided in three main categories: Indians or First Nations, Métis, and Inuit, and these are the kind of percentages. But over on the right is a slide that tells a lot. And I could sometimes in a teaching session spend a lot of time on this, but I won't. It's the demographic profile. And you can see that the blue bars represent the majority Canadian population, the mainstream, if I can use that word. And there's a very distinct baby boom profile, which I'm in that category as well, and perhaps many in the audience are, it's a relatively flat profile up until the age of 40 or 50, whereas Indigenous people have a distinctly different profile, more like low and middle income countries, which with higher percentages in the early ages and falling off much more rapidly, both for men and women. And so there's a lot of implications in this. Certainly, we're concerned about our elder health and preserving the health of our elders, but also our youth are our future. And they're an important future for Canada because if you think of the Canadian population, the Indigenous portion continues to grow, and as the rest of us are aging, we're looking to those young people to take our places, and a lot higher percentage of them will be Indigenous. So it's important that they be healthy. I will say more about the Truth and Reconciliation Commission, and Dr. Baudet mentioned it in his talk, but I want to show you the first of those recommendations, those calls to action on health, because it's a call to everyone, but certainly to governments, including Aboriginal governments, to acknowledge that the current state of Aboriginal health in Canada is a direct result of previous Canadian government policies. So the past is important, and we need to acknowledge it in order to move on. And it's not just the residential schools, it's a whole lot of other policies over 150 years, plus the previous couple of 100 years prior to our nation being formed. So I want to talk a little bit about colonization and the treaties. Non-Indigenous Canadians probably don't really want to talk about the treaties, but it's important because treaties are treaties between two groups of people. And we all signed those treaties or put our marks on them, whether they were originally the British or French governments, other governments, and individual nations. So this is a map that we use in our teaching, starting with the Haudenosaunee flag off on the far right, representing the original 5 nations of the Confederacy, and then working our way through to the Canadian flag of the 1960s. The original treaty, well, maybe not the original one, but certainly a very important one, was the 1613 treaty that's known as Goswenta, the Two-Row Wampum Belt. It wasn't actually a treaty that involved Canada at all. It was a treaty between the Dutch and the Haudenosaunee people who primarily lived in what's now New York State. But the British were the successors to that treaty when they took over New Amsterdam and made it into New York. The important thing is down at the bottom. It's a treaty of non-interference. And that was an important thing in the treaty. It was a treaty of respect for independent peoples. We shall travel down the road of life parallel to each other and never merging with each other. The 2 rows, of course, represent the European sailboat and the Native American canoe. In Canada, there was a series of treaties, starting with the East Coast and the Mi'kmaq people. And this treaty is of interest because it shows, even by the 18th century, the different views of what treaties were. The British saw them as treaties as vehicles for containment and displacement of the indigenous population, whereas the Mi'kmaq understood them as treaties, as agreements to share knowledge. And in fact, until the treaties, the Mi'kmaq didn't see the Europeans as real humans. You know, it's the opposite thing that we might think of. But the treaty formally recognized the European people as humans and agreed to peaceful coexistence. We move forward now into the 1870s, and this is now the beginning of our Confederation in Canada, which we will celebrate 150 years next year. And by then, the new Canadian government had acquired vast territories from the Hudson Bay Company and needed to establish legal title to much of that land for colonization. And this is where we get what we call the numbered treaties. Treaty 1 is the area around Winnipeg, Treaty 2, 3, all the way up to 13. And over the course of 30 years or so, there was this treaty making. And these treaties were not treaties between equals. These were treaties that were with a very weakened population on the prairies and ended up confining our peoples to relatively small tracts of land. But nevertheless, they were treaties between two people. They're established, for instance, the Treaty 6 in Edmonton and Saskatoon area that established the medicine chest, and that the principle that the federal government has fiduciary responsibility for health care for First Nations, and various court decisions have extended the application of that. But the important thing about treaties was that they were exchange of land for protection. And so there are two parts of it, but also the stewardship over the land, and we're hearing a lot about that these days. This is a quote from one of my favorite authors. His name happens to be King, and we're not related. He's an American Indian who has lived in Canada for many years, Thomas King. And he talks about the treaties, that this wasn't a moment of inexplicable generosity, the treaty rights for Native people, because Native people in North America paid for these treaties, that they gave up an awful lot for them. And in particular, you've seen this perhaps before, actually high school students get thrown out of class for wearing these t-shirts in Regina. But that's really what an important aspect. The reason that we're here on this land, here in Montreal, well, that's not a treaty area, but if we're out in Edmonton or Regina, the reason why the European settlers are there is because of the treaty. They got the majority of the land, and the First Nations agreed to live on reserves. We move into the modern era, and that actually, in a way, starts with the modern treaties here in the province of Quebec that opened up land for hydroelectric development, and then into the Northern Territories. These are, again, treaties that are much more equal. They're very large segments of land. The Inuit have 4 land claim treaties for their 4 territories, and they're much more, again, treaties between equals. And I haven't talked about British Columbia in here, but most of British Columbia is unceded territory, including the city of Vancouver, where I live. And so treaty making is still going on. It's a long process. And but various groups have been able to establish a legal basis for their treaties because they've established that they have lived there forever and have a connection with the land, and the Supreme Court of Canada has recognized that as a basis. So we get back to Thomas King, and again, I've used this in our teaching. He says, what do Indians want? Thomas is an American Indian, by the way, so he uses this kind of language intentionally. Great question. Problem is, it's the wrong question to ask. What do whites want? And again, he uses that. And it goes on that we didn't want the whites in various places, but they needed to be there because of land. And I'm not going to give I could spend the whole hour on things, but I do want to talk about the residential schools because that's the topic of this year. The Truth and Reconciliation Commission was in response to the abuses of the residential school system, and the forced removal of children was the worst of the abuse, taking children away from their parents, their families, their communities. And again, the TRC has exposed and given survivors of those schools the chance to tell their stories. It went on for more than 100 years, and you've seen pictures like this, that it disrupted our communities in an intentional way, because it really was policy of the Canadian government and its agents. And there were more than 150,000 Indigenous children who attended these schools and were separated from their families for months, even years at a time, and many didn't survive. And again, we get back to Thomas King because he presents an interesting perspective. Why did Canada choose that policy, which was a racist policy? A more sensible thing would have been to develop a partnership with various nations, as he puts, and come up with an education plan, because that's what it was about. It was getting our people educated. And they could have done that in a way that didn't require us to lose our culture, but to add value with European culture. They could have come up with an education plan that would complemented native cultures. And instead, they decided on a plan that focused on white values, and that native values, ceremonies, and languages were inferior. So it was totally the opposite of that original treaty, the Gashwenta, the Turo Wampum, which was a treaty of non-interference. And that's what happened. The other part of it is also removal of children, and that's going on even today. It started in the late 1950s and into the 60s. It was called the 60 Scoop at that time, taking children from their homes because of needs for foster care. There certainly are needs for foster care in our societies. Children need to be protected, but they didn't have to be taken out of their communities and lose those connections. And there are many people who are now adults who are struggling with the consequences of that. It's ongoing, as from our 2011 census, we find out that almost half of the 30,000 or so children in Canada who are in foster care are Indigenous. And the chances of being in foster care, if you're Indigenous, are 12 times the chance for non-Indigenous children. And as I've mentioned, most of them are placed away from their communities even today. So there's a lot more, and in our teaching we go through a lot of other factors that relate to health, poverty, gender identity, residential school, addictions, but then it turns around and resilience is important. Not everyone who went through those systems, through the foster care, through the residential schools, came out worse for it. Some of them came out strong. And we need to learn from those experiences. That's an area that we need to be able to build on to move forward, to realize that some, it may be a minority, but certainly a lot of people survived those negative experiences and came out stronger. And we need to learn from them and how we can build on it. Racism is something that we need to deal with. This is from a colleague, Cheryl Curry, who's in Lethbridge. She was a student at University of Alberta when I was there, and has this theoretical model that we've seen in other areas too, where it goes beyond the Michael Marmot causes of the causes, because it adds an underlying cause, in this case racial discrimination, that leads to biological reactions, that leads to emotional responses, that leads to negative coping mechanisms, and then ultimately to things like addictions and suicide. What this model doesn't show, and what the next one on the next slide doesn't show either, is that there's a pathway out of this downward spiral. And I think that's what I'm trying to say. We need to look at how not to have this shape our lives, because we need to look at the resilience pathway. And I think that's where we need to move forward. The other model is more complex, but it's basically the same. This comes from Yin Paradis, an Australian Aboriginal researcher. And I did actually present this one time to my colleagues at CIHR Science Council, so it does probably look familiar to some of you. And again, it's not just hocus pocus. There are real psychological stresses involved as a result of racial discrimination. There are also the physical things and the policy things. And they lead to a number of negative behaviors. And the interesting thing is that the outcomes can be both mental health outcomes like anxiety, depression, substance misuse, but also physical health outcomes, cardiovascular disease, blood pressure, physical injury. And so those things such as cardiovascular disease and suicidal behavior can have a common origin, and I think it's important to remember that. But they can also have a common way out if we can deal with the underlying mechanisms. We don't necessarily have to have 100 different solutions. There may be actually only a small number of solutions that are needed. Again, this is part of our teaching. We talk about the conventional determinants of health. These are the Ottawa Charter. As a proud Canadian, I'm happy that we got this started in the world. The income, education, employment, all of those things. And genetics are important, but they're only a part of our makeup. And then we talk about indigenous determinants of health, those deeper underlying ones, the colonization, but the positive ones, and that's where we're going, I think, in a lot of our research, promoting that connectivity to land. Michael Chandler and Chris Lalonde talked about having land claims for First Nation was a protective factor against suicide. But I think the important thing is maintaining that connections, maintaining your connections to your language and culture. And equally important, maybe more so, is the self-determination. We can't have health imposed on us. We need to be active participants and masters of our own health. And I think that's an important thing. There are other things like globalization, racism, gender, worldviews. These actually are important determinants of health, but they're probably not unique to Indigenous people. We see them all around the world. We have these worldviews, and again, there's no common worldview, but there certainly very frequently are these bonds to land and nature. Perhaps that is the common one, even though it's different in every place. Our connections with our landscape, our experiential, observational knowledge, the kinships that are important, and recognizing that extends into the spirit realm, and you know, we do acknowledge our ancestors, past and present, and things like that when we get together, and that's because we carry that common spirit with us. Indigeneity is a health determinant, and I quote the Maori scholar Sir Mason Dury here, because he made the point that indigeneity isn't a negative thing. With all the statistics, sometimes it drives me mad sometimes to see epidemiologists use indigeneity as a negative factor. It's not supposed to be that. Indigeneity is positive. It's a way of maintaining your health, of keeping your health, and I think we need to recognize that indigeneity is a good thing, and that we can use it to our advantage. So getting back to the Royal Commission on Aboriginal Peoples, that actually predated the Truth and Reconciliation Commission. It's now the 20th anniversary of that commission, and they will be holding a big event in November in Winnipeg to celebrate that in anticipation of Canada's 150th birthday the next year. I won't read all of this, but it looks very familiar. Life expectancy is lower, illness is more common, fewer children graduate from high school, the homes are bad, fewer people have jobs. It sounds just like it is today. This is 20 years later. It was an important part of Canadian history, but we didn't act on it, and we've lost 20 years. And again, to me, this is more important in a way that Aboriginal people don't want pity or handouts. They want recognition that these problems are the result of the loss of their lands and resources. And they seek a range of remedies for those, but most of all, they seek control of their lives. This was 20 years ago, and I think it's still true today. Momentous event for Indigenous people in Canada, the Truth and Reconciliation Commission. This is the picture from last December with our Prime Minister and the 3 commissioners. And this is what Justin Trudeau had to say on that day, that we will, as a country, fully implement the calls to action of the Truth and Reconciliation Commission, starting with the UN Declaration on the Rights of Indigenous Peoples. And this is the health article, or the main one, from the UN DRIP, as we call it, which talks about our right to traditional medicines, our right to access without discrimination, social health services. And the second part of it is a right to enjoyment of the highest attainable standard of physical and mental health, and the commitment of states who sign on to take the necessary steps to progressively realize this. This is a commitment by Canada to close the gap in health. And the TRC goes on. Number 18 we saw earlier, but the number 19 is the Close the Gap statement in the Truth and Reconciliation Commission, to establish measurable goals to identify and close the gaps in health outcomes, and to publish annual progress reports and long-term trends. This is a challenge for those of us in the health research industry. We need to work with Indigenous peoples to establish those goals and find better ways to report on it. We need collaboration across our provinces and territories, and it's something that CIHR as a partner in this can take on. There are more of these calls. The 22 is basically an exhortation for all of us in the healthcare system to recognize the value of Aboriginal healing practices and to use them, and to increase the number of Aboriginal professionals working in the healthcare field, and to provide cultural competency training for all healthcare professionals. I think we're making progress on that, and I'm happy with our schools of medicine and public health. It's certainly something that Alexandra and I are working on. We have now compulsory 10 hours for the incoming MPH students at Simon Fraser that I'm proud that we're able to deliver. Every MPH student will receive this kind of cultural competency training. And the final one, the number 24, is for medical and nursing schools, so that's quite relevant, I think, for people in the audience, that all students will take a course. And you need to have the history and the legacy to build on, but you also need to have the knowledge of ways forward. And reconciliation is part of that way forward. It's a pathway to Indigenous health equity that requires relationship building between Indigenous and non-Indigenous peoples. It's a partnership. So I have just 3 or 4 more slides. This is from our Institute of Aboriginal Peoples Health Strategic Plan. And we have 3 main goals, and I think these slides are being made available, so I don't need to go through everything. But the first and foremost goal really is that First Nations, Inuit, and Métis peoples and communities need to drive health research and knowledge translation that's for our benefit. We need to be partners in that, but we need our Indigenous communities to be the drivers of it. The second thing, and I've said, and it's in the TRC as well, is that we need to bring Indigenous ways of knowing into what we do in health and health research. We call it two-eyed seeing, and I'll have a slide on that in a moment. But the important thing is not to reject Western knowledge and Western ways, but to take benefit from Indigenous ways of knowing and Indigenous ways of healing in the health system. And the third thing is to recognize the strengths and resilience of First Nations, Inuit, and Métis peoples. And really, it shouldn't be just a goal to achieve health equity. What we should be doing is to achieve holistic wellness for our peoples. And there are certainly research things that we do that our institute supports that will help us get there. So this is the conceptual framework that I think is very important to it. It was put forward in this fashion by Mi'kmaq elder Albert Marshall, who called it two-eyed seeing. And it's to see from one eye with the strengths of Indigenous ways of knowing, and to see from the other eye with the strengths of Western ways of knowing, and to use both of these eyes together. So this is from a student who went through the Cadre NEAR program, Dawn Marsden, Dr. Dawn Marsden. She's a fellow Mississauga, but of the Scugog, a different reserve. And she gifted the IAPH with this series of drawings that were related to her research on urbanization. But if you look at the lower right one, the yellow background, there's a fourth era. So the first era is basically the pre-contact. We were a healthy society until contact with Europeans. Then we became very sick. And we're going through a period of revitalization, regaining our strength. And we're going to enter that fourth phase when we have recovered our strength, our resilience, and become holistically well. And that's what I want to leave you with, this upward message. Chimagwech.
No, thank you very much, Malcolm, for your presentation, and I'm glad you seriously understood the conversation that we had last night at supper, and you used it in some of your slides. Just kidding. No, I just wanted to mention that you talk about resilience, and for us in our culture and our tradition, we have what's called a condolence ceremony. And that's what we use to try to, help people who are having a hard time with some of these issues that you talk about. And so a lot of times when we do have meetings and things, we usually use that as a way of helping people. Okay? Just a comment. Yeah.
Well, thank you for that comment. And I think as part of what we're talking about today and what we're trying to achieve, looking for examples of good practice that will help us move forward, I think that's one, and there are others like it where it fits in with that idea of incorporating traditional ways of healing with the Western ways, and we could even use the not just the two-eyed seeing idea, but I could call it two-way healing. You know, to bring in both Western and traditional ways of healing, and we've got some examples of that that are coming forward that we need to pay attention to. So thanks.
Thank you.
Thank you, Malcolm. My name is Judah Denberg. I'm from McMaster University, and I'm a new fellow inductee like you. And we've talked many times. I'll propose to you an idea that you've stimulated to propose, and that's a four-eyed seeing, or at least concentrating on the maternal child dyad, because in fora of developmental origins of health and disease, that's a critical juncture. And I wonder, I don't know enough, how holistic and wellness approaches in indigenous populations are amenable to four-eyed seeing.
Thank you for that, Judah. The early childhood development phase is important, I think, for everyone, not just indigenous people, and that's been one of the areas that maybe was most critically disrupted. I don't think we know enough about early childhood development. I mean, there are a lot of scientific questions that collectively we need to address, but it does seem to be a very important thing, even perhaps more so than the disruption that occurred from 4 or 5 years old with the residential schools. And maybe that's where it gets even worse. At least those children who went into the residential schools already had those 4 or 5 years of healthy home life before they got taken away. So I think we do need to look at that. We have a program, I won't advertise it so much, but it's called Healthy Life Trajectory Initiative, and it's an important program that we are collaborating with other countries in the world that will look at those mother-child pairs and their early development.
So we have time for one more question. Yeah, thanks.
Hi, my name is Roger Strasser. I'm the Dean of the Northern Ontario School of Medicine. I want to first thank you very much for your presentation. I thought it was an excellent outline of, evidence-based outline of the challenges and the opportunities really before us. You talked about looking for examples of best practice and sharing those. So I'm interested to hear some. You just mentioned one, I guess. I'd like to hear some others, but let me tell you what we're doing with Northern Ontario School of Medicine, or just some examples anyway. We recruit Indigenous students. This year's first year medical school class, 13% of the students are Indigenous, which more or less matches the population distribution in Northern Ontario for Indigenous people. All of our medical students have a 4-week immersive experience in their first year in Indigenous communities, where they're there to learn about the history, the tradition, the culture, the social and health issues of the Indigenous people. We're just in the process of planning a remote First Nations health residency program where the residents are based in remote First Nations. And in June we held an Indigenous research gathering where we brought together the two worldviews and to develop a common ground for developing or progressing research addressing the health issues of Indigenous people. So I'm interested to hear of other examples that you could mention and maybe share with this audience.
Well, thank you for that. And I do have greatest respect for your medical school. I think it's been innovative. I'll be up in Thunder Bay in a couple of weeks and with the Native Diabetes Association, our National Association of Aboriginal Diabetes Association. I got that wrong. But some of the most important examples, I think, are ones that where, and I'm coming back to it, but we're holding another conference on pain research next Monday and Tuesday in Toronto, and the organizers encouraged me to bring some Indigenous examples and Indigenous people to it. And we have 2 or 3 presentations that will end up there where physicians or conventional medical practice combines and you get added value of Indigenous ways of doing things. One regards healing from cancer using both the best state-of-the-art medicine, Western medicine, plus traditional healing. That one actually came from your school, Cindy Pelletier. Well, she's a nurse, and then another one that comes from Six Nations, Dr. Karen Hill, a Western-trained Mohawk woman, physician, works with traditional healers in a combined clinic. Alexandra does work with traditional healers in her work in Vancouver. So I think we need to look seriously at that kind of model, and because I think we can learn from it, and I think it will deal not only with the important biomedical things, but the holistic, resilient part of health that we're trying to promote.
Thanks for your presentation, Malcolm, and for the answer to that question. I want to build on that and ask a question about methodology. One of the issues when we look at evidence is where do we get that evidence, particularly when you're dealing with the reality that one First Nations community is not the same as another First Nations community. We've tended to lump it, looking from a Western perspective, and say, everyone it's one society. It's like saying one Europe. So how do we deal with the small numbers problem in terms of the successes we have seen in communities and amalgamating that knowledge so that we can actually make some generalizations, or can we do that?
Well, that's a pretty heavy question, Carol, but thank you for that. I think it is a challenge. I'm a biomedically trained scientist. I was a numbers person for most of my career, but I think the way that we need to deal with these kind of individual, in other words, you're right. No two First Nations are the same. You can have 2 First Nations with very different health status that are otherwise seeming quite similar. I think we need to combine our epidemiological data approaches with qualitative methodology to enrich, to really find out, because I think that's the only way you can learn from these small numbers that are there, is to do that enriching kind of qualitative methodology along with the quantitative. And I think we'll learn more about, these are some methods experts down here.
So actually there was another answer, I think, over there. We have time for just one. Thanks.
Ray Wang from Laurentian University, Sudbury. Thank you very much, Malcolm, and your talk really kind of enlightened the whole issue, the culture, political issue related to the health. The last question you answered kind of make me thinking, and there's several meetings coming on these issues in Sudbury, in Thunder Bay and Toronto. I'm wondering, this is a suggestion. to be more consciousness, to be really care for all those meetings, including this one. Why we have to have them in the major metropolitan centers? Why we cannot bring all those meetings to Aboriginal community? Or kind of consider always in Toronto, Ottawa, and Montreal. I would like to see this conference really bring closer to indigenous community.
And thank you for that. That's very important. I think we do need to obviously balance, but we do need to get out to our communities. I think that's very important. I would encourage all of us to try and make those connections. Not all learning has to take place in campuses and in big cities like this. So thank you.